severe cases. So Hassan, try to speak up. So just wondering, can you hear in the last row? Okay.
It's a great pleasure to present our study's result today in front of the professor and all of you colleagues. So I'm going to summarize the findings that we've done during the pandemic during the last 2 years, specifically in a patient with the inborn of the immunity, basically the children with these disorders. So most of you may are aware about these disorders. There are almost 500 different genetic disorders of the immune system, which they can present with both gain of function or loss of function of the adaptive immunity or innate immunity. If the mutation goes beyond the non-immune system, it can present with a bone marrow failure, it can present also with a syndromic disorder. But that's not only about the germline mutation that can present this type of manifestation. If you have a somatic mutation or autoantibody against any component of the immune system, you can have phenocopies of the inborn of the immunity. So the prevalence of the disorder, we are aware that it's much varied around the globe. Basically, it can be based on the genetic background of the patients and also the facility for the diagnosis of these cases. But we also are aware that unfortunately, due to many reasons, many cases are undiagnosed and definitely these prevalence are underestimated, which those patients are probably in the risk of getting a severe disorder without being diagnosed and being a proper treatment. And that one of the reasons that we concerned from the beginning of the pandemic about these cases, we were aware about the antiviral immunity against the SARS-CoV-2, single-strand RNA basically, how it starts and how innate immunity recognize how interferon respond to it, and then how is the consequence of adaptive immunity for the T cell function and later on production of the antiviral specific antibodies. So basically, we start with the following up and doing the surveillance on the cases that we were aware in our national register in Iran. We had 2,700 cases available at the beginning of the pandemic. So we start from March 2020 until August 2020 to follow up them because this patient coming regularly to hospital for receiving their treatment. At least at this time when we had 8 follow-up for all of these cases, thanks to our peripheral centers and treating physician, and we found 19 cases by the August 2020. Majority of them were combined immunodeficiency and syndromic combined immunodeficiency. We had also some cases of the antibody deficiency and other type like congenital disorder of the phagocytes or innate immunity or autoinflammatory disorder. Death rate was super high, 42%, and the mortality rate was also 0.003. Which when you compare with that same figure in the population at that time was completely opposite. Even though we had almost 1,000 cases above age 20, majority of the case mortality was recorded below age 20 and was mainly in the age 4.25, which is completely opposite, as I said. The cases we observed in the beginning of the pandemic, most of them were about age 60, 70 years. Most of the case mortality was due to respiratory failure, as you can observe in some of those CT scans. So that was our first observation. Despite a very low, not that much higher risk of the confrontation, just 1.23-fold higher compared to the normal population, the mortality was almost 10-fold higher in these cases. The majority background of them had a bronchiectasia or cardiovascular complication or liver failure, and most of those cases with the mortality has been recorded with a combined immunodeficiency without hematopoietic stem cell transplantation and also immune dysregulation. And as I mentioned, they were children. But the key point is that we start with looking at the clinical trial of the COVID. That time was the cough, fever, and dyspnea. But with the expansion of the understanding about the COVID, we also understand that we should expand our view on the clinical manifestation. So thanks to previous speaker, I guess you are familiar now completely in the same time, the summer 2020, several groups basically with this global effort of the COVID human genetic efforts, thanks to the efforts of the Professor General Hassan Abolhassani, also to a lot of groups from the Karolinska, Hammarström labs, the Bergson labs, and Peter Brodin labs in the Karolinska. They were starting to look at the adult cases, and they found a fingerprint of interferon pathway even in adults. So basically the germline mutation or heterozygous mutation, some of them the pathway of the TLR3 pathway, and also the interferon receptor And at the same time, in another paper, they showed that 10% of the patient can have autoantibody against type 1 interferon. And also there was some kind of population-based GWAS study from adults from the different groups. I show here a kind of the meta-analysis which later published on 46 different GWAS studies. They also show the same observation. Interferon pathway is the top one when you look at the critical cases among the all different manifestations of COVID, mild, moderate, severe. Interferon alpha receptor TYK2 is there. If you narrow down, for example, for the only critical ED patients, which is published in Nature 2020, to 7,500 cases, and again interferon R1 and the TYK2 is the top genes. But when you narrow down those patients, you'll find some other fingerprint of immunity, which is a leukocyte differentiation and the myeloid cells adhesion is there. So combining these two aspects from the adults and our observation, the child with the IEI patient tried to continue these studies from the August 2020 to the November 2020 because we saw the heterogeneity of the response to the COVID and also the mortality rate. We saw that majority of those cases we are not aware about the molecular defects, and when we observed majority of the children, they are completely fine or mild. What's the reason? What's the problem of those minority of the patient? And the reason we put that cutoff, because we know with the new variants of concern, maybe the immune response will be changed, so we put the cutoff for the only patient that got a severe disorder with the wild type of the viruses, and also before the vaccination. So we know that the vaccination also can change completely the picture of the disease. So in that period of the time, we could also identify 31 patients with the inborn of the immunity. So still majority of them were male, and the median age was 12 years old. The consanguinity was 48%. And we can see a little bit improvement in the mortality rate, even though that we narrowed down now to the only severe cases ended up in the ICU or with a severe complication, that the mortality rate decreased compared to the first phase of the pandemic. And again, we can see what observation we saw before, combined with deficiency syndrome, combined with deficiency in the majority of the cases, and also immune dysregulation. But with expanding toward the other manifestation of the COVID-19, we can now see the innate immunity disorder also here. We discovered 5 cases of the MIS-C, multi-systemic inflammatory syndrome of the children. And we can see also in the manifestation of them that we now have fatigue, we have a headache, other neurological syndrome, and lymphadenopathy as well. We performed the whole exome sequencing of these cases. Fortunately, we could cover 90% of them, at least with the direct monogenic disorder. Of course, we also look at the modifier genes, which I will show in the next slide soon. The antibody production was only present, the specific antiviral response was only present in 66% of the patient. We know that some of them had a combined deficiency T-cell problem and B-cell problem, which was expected, and also autoantibody. Similar to the adults, we also see almost 6% of the patient with autoantibody against type 1 interferon. So this picture also depicts the majority of the signaling pathway, which we observed not only downstream of the TLR pathway, now TLR7, and the activation of NF-kappa B, also interferon receptor. Some genes importantly function in the B-cell maturation and T-cell maturation, regulatory T-cell functions, and also motility of the phagocytes and anti-inflammatory response afterward. When we look at the modifier genes, we discover actually that's a super accumulated number of the modifier genes in the pathway of the interferon, inflammasome response, and also in the lymphocyte development. When we compare it to the other PID patients who doesn't have any sort of the COVID manifestation, that become asymptomatic. So we contrast these two cases and we discovered this modifier genes have a very important role. Now going to focus on the 2 important cases that we discovered, which was a kind of turning point during the COVID. I guess now you are here about the TLR7, so you are very fresh. That was the first 2 cases that was published in the JAMA. And that was a kind of expected pathway because the TLR7 is there for detecting the single-strand RNA. But our observation was kind of unique because we have a 1 ataxia-telangiectasia patient, which is a syndromic combined deficiency, very typical case with the atrophy of the cerebrum, with the high level of the DNA lesion damage, and also high level of the alpha-fetoprotein. We had the 247 of those 2,700 patients that I mentioned with the ataxia-telangiectasia diagnosis, with 37 of them get COVID infection, but only 1 of them end in the ICU, unfortunately. So we performed whole exome sequencing, and there was 2 variants, both ATM and TLR7. And despite the ATM, which was a inherited mutation from the parents, TLR7 in this case was only de novo mutation, which later on we also confirmed with the agonist of the total receptor against TLR7 and TLR8, and also TLR7 specifically shows the 11% reduction of the function of this mutation compared to the wild type, which shows when you have an extra manifestation which cannot be explained with the normal phenotype of the patient or immunologic or also clinical phenotype of the patient, you should discover or should search for the extra variants, which is also we saw before in a few of the other IEI patients. So basically our theory is that why not all the IT patient or other DNA breakage syndrome show high level of the viral infection is that they produce cytosolic double-strand DNA, which accumulate the sting response and then later on improve the interferon response of the baseline of those patients. So they get actually very low level of the viral infection compared to the other PID patient or IEI patients. But if you have extra variant like a TLR7, which can diminish this pathway, you may end up with severe viral infection like a COVID-19. That was the TLR7 observation. Now we have another case which I want to also highlight a little bit. That's the concomitant of the MIS-C and the pneumonia. So at the beginning of the COVID, when we found this case, was completely unusual. Most of the experts in the field, they were saying, no, that cannot possible. Usually get a pneumonia or COVID, and then after a period of the window, you will present the inflammation. But this case was very unique, presenting at the same time inflammation and pneumonia. So that's the female case. We just have a few fingerprint of innate immunity before the presentation with the COVID, which she presented the chronic sinusitis, mucormycosis, and then she got the COVID in a very small period of the time. After a few days, she presented the dilatation of the coronary arteries, and then the score of the dilation was about the 2Z score. And actually, she was compatible with the complete diagnosis of the Kawasaki syndrome. So she had a fever lasting and the whole conjunctival membrane and also extremity chains and also lymphadenopathy. And also laboratory test was also very fit with the complete Kawasaki disorder. We performed the whole exome sequencing. The only IEI-associated non-exonic, non-syndromic, non-synonymous variant in this case was the copinome variation interferon alpha receptor, a large deletion of the exon 7 and 8. Which later on we confirmed it was actually in the one LTR region of the transposon element between intron 6 and intron 8, which delete completely exon 7 and 8. Still the patient can produce truncated protein in the cytoplasm, but the surface expression was completely diminished, and also the response to the interferon type 1 was completely low compared to the wild type when we do a luciferase assay. So now we are still on building up the correct paradigm or picture of the MIS-C in the children with the IEI, but what we found is a very interesting crosstalk of the complement system, because we also have found some new cases with the factor H, and we are aware that the interferon pathway can also regulate CD3 production toward the factor B. To end up this talk, I just want to also concentrate a little bit about current situation that we are aware, thanks to our systematic review on the 1,200 patients with IEI in the world. Still antibody deficiency, because they are most prevalent type of IEI, showing not only the crude number of the mild cases, but also the severe or late patients. But when you look at the proportion of these cases, the severity is super high in the phenocopy and also innate immunity and immune dysregulation. And when you look at the mortality, is super high in the syndromic and combined immunodeficiency. So that's a key element that the treating physician should be aware. As soon as possible, doing hematopoietic stem cell transplantation, also target the treatment if possible. When we narrow down now on the only 320 pediatric IEI patients among those 1,200 patients, which I show, we have a super high fold change of the mortality rate, 8.7 in these patients compared to 0.01% normal population. And again, combined immunodeficiency, syndromic and non-syndromic are top one reason of the mortality in the children. And regarding the monogenic disorder, which has been reported with the COVID, again, BTK is the highest regarding absolute number of the both mild and severe cases, which expected. That's one of the most common genetic disorder among IEI, also serving one regarding the hereditary edema. But when you look at the proportion of the cases, TLR7 and IV deficiency, which can produce autoantibody against the type 1 interferon, they are actually among the top dangerous or severe conditions. So just summarize all of this data I showed you. So not only interferon pathway, but also lymphocyte development, B cell development, netosis, and also complement system, specifically for the MIS-C, can be involved in the heterogeneous complication we can observe in the IR patients. So I would like to thank all of my colleagues in the pan-Hamersham groups and also my friends and colleagues in the Research Center for Immunodeficiency and all treating physicians, specifically Professor Al-Mohammadi, who passed away during this project, meanwhile of helping these children with the COVID-19. Thanks for your attention.
Thank you very much, Hassan. And we have time for 1 or 2 questions. Any questions? Yemen?
Yeah, so I mean, have you looked a little more at the CID patients in terms of their responses?
I mean, the combined immunodeficient patient was from the beginning of the pandemic in our attention, because most of these cases are unfortunately we're still in the waiting list of the waiting list on stem cell transplantation. We saw a STK4 deficiency, for example, which ended up to the mortality rate, and that was kind of a case that we showed before how much it can affect not only specifically viral infection, but also opportunistic infection in general. But in this second period, we also discovered some cases with the, as I showed, NF-kappa B1 and PI3KCD, and also some other cases with the epigenetic regulator like a DNMT3B, which was one of the top hints, which we still are performing their epigenetic study. The sample is available, and some of those patients still are available. So this was a kind of we do perform the confirmation sequencing and also kind of a preliminary functional assay, but deeply how they are really interconnected with the COVID-19 is still under investigation.
Any more questions from audience? Okay, thank you very much, Hassan. It's a pleasure to invite Professor Michel Nosensweet for his talk on B cell antibody response against SARS-CoV-2.